Welcome to the Paul Chandler Show, everyone. I am your host, Paul Chandler. Today's episode is our third installment of 27 for the ICD-10-CM Guidelines. As we mentioned before, all throughout all of March and all of April, we'll be looking at a different part of the ICD-10-CM Guidelines. Today, we'll be looking at Section 1C1 for Chapter 1, Certain Infectious and Parasitic Diseases. So stay tuned, and we'll be right back. We'll be looking at ICD-10-CM Guidelines. Welcome back, everyone. So today we'll be having our third installation on reviewing the ICD-10-CM Guidelines. And today we're in Section 1, Part C, and this is the first one that we'll be looking at for the chapter-specific guidelines, which will be for Part 1, which covers Chapter 1, Certain Infectious and Parasitic Diseases. That brings us to categories A00 through B99, and also starting this year in 2021, including the new code U07.1. So first we're going to be discussing section, I guess we can maybe call it subsection. All those, Roman numerals and whatnot just kind of get confusing. But anyways, first we're beginning with lowercase a for the human immunodeficiency virus or HIV infections. And then there are a lot of guidelines in this section, and actually in overall just chapter 1 to begin with. So I say there's a lot going on, but then looking first though at HIV, first we have though only confirmed. As far as the cases, the confirmed cases, those are the only ones that we code. And notice how the guideline states that how we only can code the confirmed cases. It's an exception to the hospital setting, which we'll be looking at quite a bit down the road when we're in Section 2. But on the outpatient side, though, and it says that in this context, confirmation does not require documentation of positive serology or culture for HIV. The provider's diagnostic statement that the HIV patient is the diagnosis for the patient, that patient is HIV positive or has an HIV-related disease or illness is sufficient. So meaning when we're coding, if the doctor just simply says patient is HIV positive, as in like the plus symbol, or just says HIV positive and spells out the word positive, or even just POS, period, that's fine. That's all that we need as far as the documentation for us to be able to code it. And then what we get starting to get tricky though is the sequencing for coding for HIV. Because normally when we're coding on the outpatient side, the main reason why the patient comes in the door that day, the chief complaint, for example, would be the primary diagnosis code. However, in HIV though, it's a little bit different. So first up, regarding the sequencing, if the patient is admitted for an HIV-related condition, and this would also apply because admitted equals inpatient. This would also apply on the outpatient side if the patient just going to the doctor's office, and if the reason for going to the doctor's office that day is for an HIV-related condition. How the guideline states that if a patient is admitted for an HIV-related condition, the principal diagnosis should be B20, as in B20, the HIV disease, followed by any additional diagnosis codes for all reported HIV-related conditions. So that's where it's different, because if a patient is going to the doctor's office for an HIV-related condition, if that HIV-related condition is the main reason why they're going to the doctor's office that day, normally we would want to put that diagnosis code first. However, though, per the guidelines, it actually would go second. Code B20 for symptomatic HIV would be the primary diagnosis code, and then whatever condition the patient's being seen for that is related to HIV would be the secondary code. So this is one of the very, very, very few times where the chief complaint, again, kind of like I like to say it, the main reason why the patient's walking in through the door that day is not listed as the primary diagnosis code. So again, if the patient has an HIV-related condition, the B20 code will go first for the symptomatic HIV, and then whatever condition that is HIV-related would go second as far as the sequencing. But then we have more of the sequencing guidelines here. that says if a patient with HIV disease admitted for unrelated condition, so as the guideline states, if a patient with HIV disease is admitted for an unrelated condition, such as, for example, a traumatic injury, the code for the unrelated condition, in this case, for example, the nature of the injury code, should be the principal diagnosis. Other diagnosis would be B20, followed by additional diagnosis codes for all reported HIV-related conditions. So what this guideline states is that if the patient is going to the doctor's office or if they're admitted to the hospital and they have HIV and they may have a related HIV-related illness, but whatever the reason why they're going to the doctor's office that day or admitted into the hospital, let's say the patient fell off their bike and broke their leg, for example. Well, that's not related to HIV. The patient just had a really bad day or had an unlucky bike moment, or however you want to call it. So if that's the case, if the patient's going to the doctor's office or being admitted into the hospital for a reason that is not related to the HIV, then whatever the non-related issue is, it could be an injury, for example, or it could be patient has a sunburn, or maybe they burned themselves on the stove or something like that. Whatever that situation is, that would be the first listed diagnosis code because it's not related to the HIV. So that unrelated code would go first, followed by B20, and then any HIV-related conditions. So that all goes back to the context of the documentation. Okay, the patient is symptomatic HIV, B20, and they have a related illness, so whatever that code is, but is the reason why the patient is needing medical care related to that HIV or not? That can drastically change the sequencing of the codes. And then we have, continuing on with the guidelines, whether the patient is newly diagnosed. And as the guideline states, whether the patient is newly diagnosed or has had previous admissions or encounters for HIV conditions is irrelevant to the sequencing decision. And so that states, and just to recap, whether the patient is newly diagnosed or has had previous admission encounters for HIV conditions is irrelevant to the sequencing decision. As in, remember, we're quoting for today, not for anything in particular in the past. But now the patient could be asymptomatic. So the B20 code, that covers a related complex, or ARC, A-R-C, AIDS, and then HIV symptomatic. So all three of those are just grouped together in the B20 category and the B20 code. But the patient could be asymptomatic having HIV. Then instead of B20 for symptomatic HIV, we would code that as Z21 for asymptomatic. So remember, so the term symptomatic, they're showing symptoms, and then asymptomatic, they're not showing any symptoms. So as the guideline states, Z21, asymptomatic HIV infection status, is to be applied when the patient, without any documentation of symptoms, is listed as being HIV positive, known HIV, HIV test positive, or similar terminology. Do not use this code for the term AIDS if used, or if the patient is treated for any HIV-related illness or is described as having any conditions resulting from his or her HIV positive status. Use B20 in these cases. Just like I explained before, that B20 for symptomatic, C21 asymptomatic HIV. Because until there's a cure one day, patient will be either one, asymptomatic or symptomatic. So you think of a Z21 as asymptomatic as being the patient has HIV, the HIV positive, but everything's fine. Perfectly healthy, everything's okay, but oh, by the way, they have HIV. So again, they have no related conditions that are related to HIV, nor do they have any symptoms going on. It's comma, oh, by the way, patient's HIV positive. Now here we have a chart telling with the asymptomatic. So first, and going down from the top to bottom of the decision tree chart, a patient is seen for a condition and has asymptomatic HIV, so Z21. And then is the condition the patient is being seen for related to HIV? If the answer is yes, then we use the B20 code as the first listed diagnosis code, followed by any additional related conditions. as additional codes. Or if the condition that the patient is being seen for is not related to HIV, then we report the unrelated condition first, followed by Z21 to indicate the patient's asymptomatic HIV status. That just kind of puts just in the context what we just discussed as far as the symptomatic or asymptomatic. And next we have, there are a lot of HIV codes here, and a lot of codes, hence a lot of guidelines. And the next we have for patients with inconclusive HIV serology. So patients with inconclusive HIV serology, but no definitive diagnosis or manifestations of the illness may be assigned code R75, inconclusive laboratory evidence of HIV virus. So translation, actually HIV virus, that's not right. HIV, because the V in HIV is virus. So inconclusive laboratory evidence of HIV. There we go. So what this means is that if a patient has tested for HIV and if the results are inconclusive, unable to determine, non-determinable, something like that, then instead of diagnosing the patient as being positive when it could be negative or vice versa, then as far as the coders, we'll select the R75 code, showing that it's inconclusive. That way, say for example, today we're not coding it HIV positive to find out maybe next week when they come back to get retested, it may be negative. Then that could appear like, oh, what did the patient do between last week and this week to cure the HIV? What did they eat? What did they drink? Did they do any exercises? Whatever they did. That's not how it works. So to prevent a false positive, false negative result, we would code R75 simply saying, I don't know. We're not able to tell it. It's inconclusive. And usually the documentation will state that the patient's been requested to come back and get tested again. But then we have also, continuing on with the guidelines here, the previously diagnosed HIV-related illness. And like the guideline states, patients with any known prior diagnosis of an HIV-related illness should be coded to B20. Once a patient has developed an HIV-related illness, the patient should always be assigned code B20 on every subsequent admission encounter. Patients previously diagnosed with any HIV illness, B20, should never be assigned to R75 or Z21, asymptomatic HIV infection status. So translation, once you go to B20, you always stay B20. So there's no yo-yoing back and forth between the B20 B20 symptomatic, Z21 asymptomatic, B20 symptomatic, Z21 asymptomatic, or maybe let's throw in an R75 in there somewhere for inconclusive lab test. So they're just saying that once the patient has an HIV-related illness, we'll always be coding it B20, never going back to the R75, the inconclusive lab results code, or the Z21, the asymptomatic HIV status. Then the second to last part here, discussing the HIV for coding, HIV infection in pregnancy, childbirth, and the propernium. As the guideline states, that during pregnancy, childbirth, or the propernium, a patient admitted or presenting for a healthcare encounter because an HIV-related illness should receive a principal diagnosis code of O98.7 hyphen, because it needs more characters. So the principal diagnosis code of O98.7 hyphen, HIV disease complicated pregnancy, childbirth, and the propernium, followed by B20 and the codes for the HIV-related illness. And the codes from Chapter 15 always take sequencing priority. Chapter 15, which we'll discuss when we get to that point, because starting Chapter 1 onward, the OBGYN codes. Those begin with the letter O, hence OBGYN. And those codes always take priority. So those will go first before a B20, for example. And the patient with asymptomatic HIV infection admitted or presenting for healthcare encounter during pregnancy, childbirth, and the propernium should receive codes O98.7 hyphen, because again, we need more characters, and Z21. So simply put, if the patient is obviously female and pregnant, then an O98.7 hyphen, for depending on what trimester the patient's in, that will always go first. And then we resume the normal B20 or Z21 guidelines. And one thing though too, with the O98.7, how it says HIV disease complicating pregnancy, and all these quote unquote complication codes in the O categories, don't get stuck on the word complication or complicating, or however it's, whenever you're reading, however you phrase it. Because to me, the word complicating it means something like there's complications going on, but that's not necessarily, because the female patient could have a smooth sailing, everything's fine, no issues whatsoever, pregnancy, but they're HIV positive. That's still considered quote unquote a complication, even though if it physically doesn't complicate the pregnancy itself or the childbirth itself or the perponium itself, as in, like, think of it as the phrase like it's smooth sailing, that's fine. We still need the O98.7 code in that case. And then the last part are just for the guidelines though, relating here for HIV, we have encounters for testing for HIV. As the guideline states, if a patient is being seen to determine his or her HIV status, use code Z11.4, encounter for screening for HIV. Use additional codes for any associated high-risk behavior. If a patient with signs or symptoms is being seen for HIV testing, code the signs and symptoms. An additional counseling code of Z71.7, HIV counseling, may be used if counseling is provided during the encounter for the test. When a patient returns to be informed of his or her HIV test results and their test result is negative, use code Z71.7 HIV counseling. If the results are positive, see the previous guidelines and assign codes as appropriate. So translation, because we always have to have diagnosis codes on a claim form, if the patient is going to the doctor's office to get an HIV test, the encounter for the testing itself, we would add the Z11.4 code to that encounter as far as the coders. But then if the doctor just mentions the HIV condition and quote unquote counsels the patient on it, but then also if they come back and get the test results and it's negative, then we would add the Z71.7 code for the counseling of the HIV condition. So now, good news is though, that's all for HIV. And I know that is a lot of the HIV guidelines in there just for a small amount of codes, and a lot of them are the 3 characters, maybe 4. But it's just that we have a lot of weird tricks to the trade, if you will, as far as the coding. So we have a lot of guidelines that don't follow the normal procedures. So then in chapter 1, so then lowercase b here, kind of segueing away from HIV, now we have infectious agents as the cause of disease classified to other chapters. And this is important to note because with this chapter being certain infectious and parasitic diseases, as the guideline states, that certain infections are classified in chapters other than chapter 1, and no organism is identified as a part of the infection code. In these instances, it is necessary to use an additional code from chapter 1 to identify the organism. A code from category B95, Trachococcus, Staphylococcus, and Enterococcus as the cause of diseases classified to other chapters, and B96, other bacterial agents as the cause of disease classified to other chapters, and B97, viral agents as the cause of diseases classified to other chapters, is to be used as an additional code to identify the organism. And an instructional note will be found at the infection code advising that additional organism code is required. So translating this part of the guidelines, that there are other infection codes outside of this chapter 1 covering infections, and when that happens, we'll still need an additional code somewhere in the B95, B96, or B97 code to identify the organism itself. And when that occurs, whatever code we're looking at in a different chapter that covers the infection, there will be a use additional code note to state that use additional code to identify organism. And then it'll tell you to see B95, B96, or B97. That way we can link whatever infection is in the other chapter with the organism itself here in chapter 1 in that case. Now with lowercase c, infections resistant to antibiotics. As the guidelines here state, many bacterial infections are resistant to current antibiotics, It is necessary to identify all infections documented as antibiotic resistant and assign a code from category Z16, resistance to antimicrobial. There we go. Now for lowercase c, infections resistant to antibiotics, as the guideline. And as the guide. And now for lowercase c, infections resistant to antibiotics. As the guideline states, many bacterial infections are resistant to current antibiotics. It is necessary to identify all infections documented as antibiotic resistant. Assign a code from category Z16, resistance to antimicrobial drugs, following the infection code only if the infection does not identify drug resistance. So translating what the guideline says is that if the infection itself not responding to antibiotics, then we just add code Z16, resistance to antimicrobial drugs, and then whatever infection that the patient is experiencing at that time. Now, while the HIV section had a lot of guidelines there, same thing here now, but for lowercase d, sepsis, severe sepsis, and septic shock. So first, in lowercase d number 1, we have coding for sepsis and severe sepsis, because they're similar, but just a little bit different on a couple things. So first, regarding sepsis, as the guideline states, for an additional diagnosis, and now for lowercase d, sepsis, severe sepsis, and septic shock. Now, just like the HIV section or subsection, the subsection for here has a lot of guidelines also, so let's go. Number 1, for coding for sepsis and severe sepsis. Lowercase a, first we're going to talk about sepsis. For a diagnosis of sepsis, assign the appropriate code for the underlying systematic infection. If the type of infection or causal organism is not further specified, assign code A41.9, sepsis, unspecified organism. A code from subcategory R65.2, severe sepsis, should not be assigned unless severe sepsis or an associated acute organ dysfunction is documented. So first, that's just the generic difference between sepsis and severe sepsis, between one and then the second one. While sepsis, with unspecified organism, is the A41.9 code. With severe sepsis, the organ has to have a quote-unquote dysfunction going on. If there's no organ dysfunction, then it's just standard sepsis, if you will. I know we don't call it standard, but just normal sepsis. But if the patient is experiencing organ dysfunction, then that sepsis code gets upgraded, if you will, to a severe sepsis code. Now, first though, we have lowercase number 1, or lowercase I, negative or inconclusive blood cultures and sepsis. Negative or inconclusive blood cultures do not preclude a diagnosis of sepsis in patients with clinical evidence of the condition. However, the provider should be queried. So simply put, as far as the coder side, that if the patient's blood results come back negative or inconclusive, we do not say the patient does not have sepsis. That, if just looking at the blood cultures, we do have to query the provider and ask, hey, I need to know, is there sepsis, yes or no, in the patient itself? Because remember, that's one thing as far as coders, we don't look at lab results and diagnose the patient from those lab results. That's the doctor's job. We're just here just to translate the documentation into the codes, and that's it. But then we have urosepsis, which is the term urosepsis is a non-specific term. It is not considered synonymous with sepsis and has no default code in the alphabetical index. Should a provider use this term, he or she must be queried for clarification. Translation: it's not a real thing. Doctors sometimes use big fancy words that they hear or read somewhere or they like to use, and as far as coders, that means absolutely nothing to us. Urosepsis is one of those conditions. It's not a real condition. So if a provider uses urosepsis, send it back, ask them, hey, what's really going on here? In polite terms, though, of course. And then lowercase I, number 3, sepsis with organ dysfunction. If a patient has sepsis and associated acute organ dysfunction or multiple organ dysfunction, known as MOD, follow the instructions for coding severe sepsis. Just kind of like what I mentioned before, that the patient has the documentation of sepsis, but also mention the documentation of some, and it doesn't matter which one, but as far as organ dysfunction, we would actually code that as severe sepsis. So you can think of it as sepsis plus organ dysfunction equals severe sepsis in that case. And then number 4, acute organ dysfunction that is not clearly associated with the sepsis. That's something that we have to watch out for, because patient can have sepsis but also have organ dysfunction, and do they go together or not? So as the guideline states, if a patient has sepsis and an acute organ dysfunction, but the medical record documentation indicates that the acute organ dysfunction is related to a medical condition other than the sepsis, do not assign a code from subcategory R65.2 severe sepsis. An acute organ dysfunction must be associated with the sepsis in order to assign the severe sepsis code. If the documentation is not clear as to whether an acute organ dysfunction is related to the sepsis or another medical condition, query the provider. Translation: we have to know as far as coders, is that organ dysfunction related to the sepsis or not? If it is related to the sepsis, just like I mentioned on the last part, that sepsis plus organ dysfunction equals severe sepsis, but if it's related. So then if the patient has sepsis and has organ dysfunction, but those are not, or actually it goes like this, like not related, then we would not code it as a severe sepsis. If that patient's organ dysfunction is not related to the sepsis, we would code it as just sepsis and organ dysfunction, and that's it. And then, but continuing on though, just a little bit more clarifications though on severe sepsis. So part B, the coding for severe sepsis requires a minimum of 2 codes. First, a code for the underlying infection, followed by a code from the subcategory R65.2 for severe sepsis. If a causal organism is not documented, assign code A41.9, sepsis unspecified organism, for the infection. Additional codes for the associated acute organ dysfunction are also required. Due to the complex nature of severe sepsis, some cases may require querying, I don't like it when those 2 words are together, require querying the provider prior to assignment of the codes. So translation, when we have severe sepsis, yes, we need to do the code R65.2, but that is just like saying patient has R65.2 severe sepsis. Yes, patient has sepsis and organ dysfunction, but just with that code itself, R65.2, I got a secret and I ain't gonna tell you which organ is having that dysfunction. Hence, we need the second code, an additional code, to specify what organ specifically is dysfunctioning, and based on that, for the reason, that's why we code the underlying systemic infection. So we have sepsis, severe sepsis, but now we also have septic shock. And this has quite a few guidelines as well. So first of all, septic shock generally refers to a circulatory failure associated with severe sepsis, and therefore it represents a type of acute organ dysfunction. For cases of septic shock, the code for the systemic infection should be sequenced first, followed by the code R65.21. Severe sepsis with septic shock, or code T81.12, post-procedural septic shock. And additional codes for the other acute organ dysfunctions should also be assigned. As noted in the sequencing instructions in the tabular list, the code for septic shock cannot be assigned as a principal diagnosis. So translating these guidelines, that if the patient has septic shock, then first we would code whatever systematic infection the patient's has going on. So that'd be the first diagnosis code. And then the second code would be the R65.21, severe sepsis with septic shock, or if that septic shock is due to post-procedural, as in like post-op. So if our documentation states the patient had a procedure that then caused the patient to have septic shock afterwards, instead of doing R65.21, we would code T81.12. But that, though, too, has to have the correlation mentioned in the documentation of the septic shock is related to post-op, any type of post-op care that the patient was receiving. If there's no mention of a previous procedure recently and the patient has septic shock, then we would code R65.21, again, if there's no post-procedural timeline going on. And then now with sequencing of severe sepsis, as the guideline states, if severe sepsis is present on admission and meets the definition of principal diagnosis, the underlying systematic infection should be assigned as principal diagnosis, followed by the appropriate code from subcategory R65.2 as required by the sequencing rules in the tabular list. A code from subcategory R65.2 can never be assigned as the principal diagnosis. When severe sepsis develops during an encounter, meaning it was not present on admission, but the patient got it while they were in hospital, the underlying systematic infection and the appropriate code from subcategory R65.2 should be assigned as a secondary diagnosis. Severe sepsis may be present on admission, but the diagnosis may not be confirmed until sometime after admission. If the documentation is not clear whether severe sepsis was present on admission, the provider should be queried. So translating this guideline, in how R65.2, the severe sepsis code can never be listed first, but then looking at the documentation, if it's severe sepsis is present on admission, then we would still code the underlying infection first as a principal diagnosis, followed by then the R65.2 for severe sepsis. But then when sepsis it happens during the encounter, as in like while they're inside the hospital, we still code the underlying infection first, followed by the R65.2 code second in that case. Now then number 4, sepsis or severe sepsis with localized infection. As the guideline states, if the reason for admission is sepsis or severe sepsis and a localized infection, such as pneumonia or cellulitis, a code or codes for the underlying systematic infection should be assigned first, and the code for the localized infection should be assigned as a secondary diagnosis. If the patient has severe sepsis, a code from subcategory R65.2 should also be assigned as a secondary diagnosis. If the patient is admitted with a localized infection, such as pneumonia, and severe sepsis doesn't develop until after admission, the localized infection should be assigned first, followed by the appropriate sepsis or severe sepsis codes. So translating this, that just like how it was with the underlying infection code going first and then the R65.2 going second, that the patient has then the localized infection, still the underlying systematic condition that's related to the severe sepsis, that still gets listed first. But then secondary, though, would be the local infection code. And then if the patient has severe sepsis, then the R65.2 would be added. So again, so as far as sequencing, the code for the underlying systematic infection will always be going first, but then the patient develops in a localized infection, then that code would be listed second. And then followed by the R65.2 if that applies for the severe sepsis. Now we do have quite a bit handful here of guidelines involving now we're talking about the sepsis due to a post-procedural infection. So post-op, patients had a procedure, now it's after the procedure, an infection develops. And part A here says documentation of causal relationship. As with all post-procedural complications, code assignment is based on the provider's documentation of the relationship between the infection and the procedure. So again, so we need to be able to have that relationship, that cause and effect relationship, to be able to document it that the sepsis itself is due to a post-procedural infection. If there's no cause and effect relationship in the documentation, we never assume. So then we would just assume the patient's having really bad luck, if you will, and they're post-op and now they got sepsis. Again, so we need that relationship, the cause and effect relationship mentioned in the documentation, to be able to classify the sepsis due to a post-op infection. Now then, continuing on though, the sepsis due to post-procedural infection for Part B, as the guideline states, for infections following a procedure, a code from T81.40 to T81.43 in that range, infection following a procedure, or a code from O86.00 through O86.03, infection of obstetric surgical wound that identifies the site of the infection should be coded first, if it's known. Assign additional codes for the sepsis following a procedure, T81.44, or sepsis following an obstetrical procedure, O86.04. Use an additional code to identify the infectious agent. If the patient has severe sepsis, the appropriate code from subcategory R65.2 should also be assigned with additional code or codes for any acute organ dysfunction. For infections following infusion, transfusion, therapeutic injection, or immunization, a code from subcategory T80.2, infections following infusion, transfusion, and therapeutic injection, or code T88.0 hyphen, remember hyphen for additional characters are needed. The T88.0 hyphen, infection following immunization, should be coded first, followed by the code for the specific infection. If the patient has severe sepsis, the appropriate code from subcategory R65.2 should also be assigned with the additional codes for any acute organ dysfunction. So translating this guideline, that if we're in a post-op situation, we would add the T81.40 through the T81.43, any code in that range there, infection following a procedure, or O86.00 through O86.03 if it's following an OB, an obstetrical surgical procedure. That'd be the first diagnosis code, depending on what type of surgery it was. So the T81s or O86s would go first. And then we would have the T81.44, the sepsis following the procedure. That's be linked with the other T81 codes. Or the O86.04 would be attached to the other O86 codes. And then we would use an additional code also, so now it's up to 3 codes, to identify the infectious agent itself. And that'd be code number 3 in the priority list there. And then if the patient has severe sepsis, then we need a 4th code in the R65.2 for any acute organ dysfunction. But then if the patient is having the infections after any infusions, transfusions, therapeutic injections, or immunizations, then we'd have to add a code from the T80.2 or the T88.0 hyphen. That'd be first, followed by the code for the specific infection itself. And if the patient has severe sepsis, then the good old R65.2 would be listed third in that case. And that's one thing that's important to remember, that guidelines are important, but also then the sequencing of the codes are important as well. Still going on with the guidelines here for sepsis, and now we have post-procedural infection and post-procedural septic shock. As the guideline states, if a post-procedural infection has resulted in post-procedural septic shock, assign the codes indicated above for sepsis due to a post-procedural infection, followed by code T81.12 hyphen, post-procedural septic shock. Do not assign code R65.21, severe sepsis with septic shock. Additional codes should be assigned for any acute organ dysfunction. So translating these guidelines, if the post-op infection, if it's resulting itself from the post-procedural septic shock, then we assign the code first, again sequencing here. First we do the appropriate code for the sepsis due to post-procedural infection, then the T81.12 hyphen for the post-procedural septic shock, We would not do, though, the R65.21, severe sepsis with septic shock. Then that's one thing, we never code those two codes together. We just code the T81.12 hyphen, because if we were to add the R65.21, we're essentially doubling the septic shock. And just because if it hurts really bad, that does not mean we get to double the code. So we'd only do the T81.12 hyphen in that case. And then, so the infection itself for the resulting from the post-procedural shock, that would go first. And then the sepsis due to post-procedural infection, followed by then the T81.12 hyphen. And now part number 6, we're only 4 more parts, counting this one, left in this sepsis, severe sepsis, and septic shock for the guidelines. So here we have number 6, sepsis and severe sepsis associated with non-infectious process, such as a condition. And as the guideline states, in some cases, a non-infectious process or condition, such as a trauma, may lead to an infection which can result in sepsis or severe sepsis. If sepsis or severe sepsis is documented and as associated with a non-infectious condition, such as a burn or serious injury, and the condition meets the definition for principal diagnosis, the code for the non-infectious condition should be sequenced first, followed by the code for the resulting infection. If severe sepsis is present, a code from subcategory R65.2 should be assigned with any associated organ dysfunction codes. It is not necessary to assign a code from subcategory R65.1 for SIRS, which stands for Systemic Inflammatory Response Syndrome, of non-infectious origin for these cases. So translating these guidelines, that the patient has a non-infectious condition, and then if then the sepsis or septic shock is, sepsis or severe sepsis, I should say, is a result of it, then we would code the non-infectious condition. But then as far as the sequencing, how it says, then the code for the non-infectious condition should be sequenced first, followed by the result for the infection. So whichever is the non-infectious condition would be first, and then, such as, for example, the trauma, and then second would be whatever infection develops from that non-infectious condition. And then if the patient has severe sepsis, then we would do the R65.2, but that'd be the third code in there. Now then, if the infection meets the definition of a principal diagnosis, it should be sequenced before the non-infectious condition. When both the associated non-infectious condition and the infection meet the definitions of principal diagnosis, either may be assigned as principal diagnosis. Only one code from subcategory R65, symptoms and signs specifically associated with systemic inflammation and infection, should be assigned. Therefore, when a non-infectious condition leads to an infection resulting in severe sepsis, assign the appropriate code from subcategory R65.2, severe sepsis. Do not additionally assign a code from subcategory R65.1, SIRS, of non-infectious origin. And it does see here in a little bit, actually in chapter 18, that you'll be looking at the guidelines for SIRS. But just to translate what this guideline states, that if the infection is notated as, yes, we can use it as a principal diagnosis, then we would code it before the non-infectious condition. If both the non-infectious condition and the infection itself are listed as possible principal diagnosis codes, then sequencing doesn't matter in that case. So this is where we always have to check our ICD-10 book and check to see which codes are applicable to be able to be coded first or not. And then we would only have one R65 code, no matter what we're dealing with. As far as that category, just like I mentioned before, that the patient is septic shock and severe sepsis and whatever else is going on, it doesn't make it worse if you do the code twice. So we'd only ever have one code in the R65 category in that case. Now then, wrapping up the sepsis, severe sepsis, and septic shock, and if Peter Piper could pick up pickled peppers, how many peppers could Peter Piper pick in that case? So now on the sepsis and severe septic shock, complicating abortion, pregnancy, childbirth, and the perineum, that is actually discussed further down the road in Chapter 15 in the OBGYN codes. And then for newborn sepsis, that is again discussed farther down the road in Chapter 16, where we'll be looking at the newborn codes. Now we do have this really cool little guideline chart here to help us out on how we code the sepsis format. So looking at this, first, is a patient admitted with sepsis? Okay, then continue on. Does the patient have organ dysfunction? If not, then report A41.9 or the appropriate code for the underlying systemic infection. Or if there is organ dysfunction, then is the organ dysfunction clearly associated with the sepsis? If it is, then this makes the diagnosis severe sepsis. We would first report A41.9 or the appropriate code for the underlying systemic infection first. Second, we'd report the code in the R65.2 subcategory, so R65.2 hyphen. And then third, any additional codes to identify the systemic acute organ dysfunction. But if the organ dysfunction is not related to the sepsis, then we still report the A41.9 or the appropriate code for the underlying systemic infections. And then secondly, we report the code for the organ dysfunction itself. So this comes into play where we have to look at the documentation and always check to see if there's that cause and effect relationship there. So now that we can leave sepsis and all that, now let's talk about MRSA, MRSA. So first we need to discuss though, and that's I don't like these big fancy medical words. Methicillin-resistant Staphylococcus aureus. There we go. Conditions. And so we have first selection and sequencing of the MRSA codes. So first in lowercase a, we're going to discuss combination codes for MRSA infection. When a patient is diagnosed with an infection that is due to, I'll just say MRSA, and that infection has a combination code that includes the causal organism, such as sepsis or pneumonia, assign the appropriate combination code for the condition. For example, code A41.02, sepsis due to MRSA, or J15.212, pneumonia due to MRSA. Do not assign code B95.62, MRSA infection as a cause of disease classified elsewhere, as an additional code because the combination code includes the type of infection and the MRSA organism. Do not assign a code from subcategory Z16.11, resistance to penicillins, as an additional diagnosis. So translation, what that means is that depending on what the condition is, some conditions have the combination codes, whatever condition plus MRSA, and other times they don't. But whenever you have the two conditions, whatever other condition the patient has, and MRSA, when it's a combination code, we only choose that one code. That includes the MRSA component in it. If the condition does not have a MRSA combination code to it, then we need the two codes, whatever other condition the patient has and the MRSA. Because if we were to, for example, the A41.02, sepsis due to MRSA, if we were to choose that code and then that combination code and then add a second code for MRSA, then that would be redundant and we'd be doubling the MRSA. And you don't double the condition at all because you only have MRSA once and that's it. So then based on the documentation, whenever there's a combination code that includes the condition and MRSA, patient has both, we just choose the one code. But whenever the code does not include MRSA, patient has a condition and MRSA, then we need to do the two separate codes in that case. And then 1B, other codes for MRSA infection. When there is a documentation of a current infection, such as a wound infection, stitch abscess, or UTI, urinary tract infection, due to MRSA, and that infection does not have a combination code that includes the causal organism, assign the appropriate code to identify the condition along with code B95.62, MRSA infection as a cause of disease classified elsewhere for the MRSA infection. Do not assign a code from subcategory Z16.11, resistance to penicillins. So translation, if the patient has an infection that is due to MRSA, but when there's no combination code, just like how I just mentioned, we code whatever other condition the patient has first, followed by then the MRSA code B95.62 second. So when there's no combination code available, we have to choose the two separate codes in that case. Just two more parts dealing with MRSA, then we'll talk about Zika virus, and then we'll talk about COVID-19. So starting to wrap up here on MRSA, for MESA, MSSA, and MRSA colonization. So MSSA, methicillin susceptible Staphylococcus aureus. As the guideline states, the condition or state of being colonized or carrying MESA or MRSA is called colonization or carriage, while an individual person is described as being colonized or being a carrier. Colonization means that MESA or MRSA is present on or in the body without necessarily causing illness. A positive MRSA colonization test may be documented by the provider as MRSA screen positive or MRSA nasal swab positive. Assigned code Z22.322, carrier or suspected carrier of MRSA for patients documented as having MRSA colonization. Assigned code Z22.321, carrier or suspected carrier of MESA for patients documented as having MESA colonization. Colonization is not necessarily indicative of a disease process or as the cause of a specific condition the patient may have unless documented as such by the provider. So translation, so we have the MESA MSSA code Z22.321, and then the MRSA MRSA code Z22.322. When the patient has positive results, they're quote unquote colonization, they're colonizing it. So as in they have it, but it's not causing any other illness. So think of it as asymptomatic, MRSA or MESA. Then we would choose those appropriate codes. And now to wrap it up, so then we have the MRSA colonization and infection, which actually we just talked about on the last guideline, but as you can see, sometimes the guidelines are repetitive. So we have 1D, MRSA colonization and infection. If a patient is documented as having both MRSA colonization and infection during hospital admission, code Z22.322, carrier or suspected carrier of methicillin-resistant Staphylococcus aureus, and a code for the MRSA infection may both be assigned. So translation, patient is colonized MRSA, and they have an infection during the admission process, then we do the two codes. We do the Z22.322 code for the suspected carrier or carrier of MRSA, hence colonization, and then whichever code for the MRSA infection the patient is experiencing. We do the both codes in that case. And for Zika virus infections, only one part and that's it. So first of all, we only code the confirmed cases. Code only a confirmed diagnosis of Zika virus, A92.5, for Zika virus disease, as documented by the provider. This is an exception to the hospital inpatient guidelines, section 2H, which we'll talk very much towards the end. In this context, confirmation does not require documentation of the type of test performed. The provider's diagnostic statement that the condition is confirmed is sufficient. This code should be assigned regardless of the stated mode of transmission. If the provider documents suspected, possible, or probable Zika, do not assign code A92.5. Assign the codes explaining the reason for the encounter, such as a fever, rash, or joint pain, or Z20.821, contact with or suspected exposure to Zika virus. So just like anything else, regardless, when we're medical coding, we only code the confirmed cases. Patient has a confirmed confirmed Zika virus. We'd code that just the good old A92.5. If it's not confirmed, but the doctor thinks they may have it, then we would code whatever conditions the patient have. We'd code just the signs and symptoms, or the Z20.821 code if the patient is suspected to have contact or suspected to exposure to the Zika virus in that case. So you can see, as you can see here, that keywords always do matter when we're coding. Okay, so now with the COVID-19, that's what we call it for short, as far as these guidelines, which are new to 2021. So first of all, only code confirmed cases. That if a patient has a confirmed diagnosis of COVID-19, we would assign that with code U07.1. This isn't exceptional to the hospital's guidelines, which again we'll look at towards the end of this whole 2 months of looking at the guidelines when we look at section 2, part H. But then if the doctor does not have a positive COVID-19 test result, but they're ordering a test, maybe possible, rule out, probable, just like the others, we would not, just like the other guidelines for other conditions, we would not code COVID-19 if the patient is not confirmed to have it. We would code any signs and symptoms the patient would have until we get a positive COVID-19 result, if that is the case, down the road. So patient is diagnosed as confirmed COVID-19 positive, we'd code U07.1. If there's not a positive test results back, then we code the signs and symptoms. But now the sequencing of the codes. So with COVID-19 meets the definition of a principal diagnosis, we'd code U07.1 first, followed by the appropriate codes for associated manifestations, except when other guidelines require that certain codes be sequenced first, such as OB, sepsis, or transplant complications. So we already discussed the sepsis rules and the severe sepsis and septic shock, but then we'll look at in chapter 15 rules for COVID-19 when a patient is also experiencing the pregnancy, childbirth, and the peritoneum. And we'll discuss again the COVID-19 guidelines in chapter 16 with COVID-19 in a newborn. And then we'll discuss COVID-19 again in chapter 19 when we're dealing with transplants as far as that. Now then, if a patient is having acute respiratory manifestations of COVID-19. So when a reason for the encounter or admission is respiratory manifestation of COVID-19, assign code U07.1 as the first or the principal diagnosis, followed by any respiratory manifestations as the additional diagnosis. For example, if the patient has COVID-19 and pneumonia, then we would code U07.1 as the primary diagnosis for the COVID-19, and then the J12.89 for the other viral pneumonia. Patient has acute bronchitis confirmed that is due to COVID-19, we'd code the U07.1 first, followed by the J20.8, acute bronchitis due to other specified organisms, code second. The patient has bronchitis, for example, that's due to COVID-19, we'd code the U07.1 COVID-19 code first, and then the J40 code for bronchitis, not specified as acute or chronic, second. Patient has a lower respiratory infection, or an LRI, that is due to COVID-19, we'd code the U07.1 COVID-19 positive diagnosis code first, followed by J22, unspecified acute lower respiratory infection. And the patient has COVID-19 being associated with a respiratory infection, not otherwise specified, an OS, then the U07.1 code goes first, followed by the J98.8, other respiratory disorders, as second. So COVID-19, if the patient has a condition that's related to COVID-19, notice how all of these codes, the COVID-19 code goes first for U07.1, followed by what other else the patient is experiencing, whatever other conditions. Now then, if the patient has acute respiratory distress syndrome, or ARDS, ARDS, due to COVID-19, then we would code the U07.1 for COVID-19 first, followed by the J80 code, acute respiratory distress syndrome. Or if patient's having acute respiratory failure that's due to COVID-19, the U07.1 code for COVID-19 goes first, followed by the appropriate J96.0 hyphen code, acute respiratory failure, goes second. Remember, hyphens mean we need additional codes. I'm going to cover my verbiage. Hyphens mean we need additional characters in the code. There we go. But now if a patient is having a non-respiratory manifestations of COVID-19, then we would assign still the U07.1, the COVID-19 code first, as the principal diagnosis, and then any additional codes for the manifestations would go next. So it all depends on what manifestations it is. It could be like the guidelines state, viral enterinitis, doesn't matter what it is. If it's a non-respiratory manifestation that's due to COVID-19, the U07.1 code always goes first, followed by whatever manifestations, the coding for those that the patient's experiencing. But then we have exposure to COVID-19 codes. So not all just confirmed diagnosis codes. Exposure to COVID-19, Z20.828, contact with and suspected exposure to other viral communicable diseases. So there's not a code that specifically states exposure to COVID-19. They just group them together with other viral communicable diseases. And then as continuing on with the guidelines, for symptomatic individuals with actual or suspected exposure to COVID-19 and the infection has been ruled out or test results are inconclusive or unknown, assign code Z20.828, contact with and suspected exposure to other viral communicable diseases. Now, screening for COVID-19. A screening code is not generally appropriate during the pandemic, but notice the verbiage in this guideline here. During the COVID-19 pandemic, which we're still in as of the date of this recording, a screening code is not generally appropriate. For encounters for HIV testing, include preoperative testing code as exposure to COVID-19, which we just talked about. Coding guidelines will be updated as new information concerning any changes in the pandemic status become available. So again, this guideline here is only accurate as of the date of this recording, which I will say is Monday, March 8th, 2021. And then with the signs and symptoms without definitive diagnosis of COVID-19, just like how all the other guidelines state, when you don't have a definitive diagnosis, you code all the signs and symptoms. So for example, cough, shortness of breath, and fever. If the patient does not have a definitive diagnosis of COVID-19, but has those signs, or in this case, those symptoms, we would code those symptoms. R05 for cough, R06.02 for shortness of breath, and R50.9 for fever unspecified. As the last part of this guideline states, if a patient with signs and symptoms associated with COVID-19 also has an actual or suspected contact with or exposure to COVID-19, assign Z20.828, contact with and suspected exposure to other viral communicable diseases as an additional code. Again, so that's why it's always important for the providers to give us the accurate documentation to state if the patient is exposed to it or not. And I will actually take a brief moment here to state with the guidelines. For example, I was proctoring an exam on site, actually August, I think it was, August or September last year. And I was negative tested before I went. We were all social distancing during the exam. And it was on site with one of our clients. And I got an email, the exam was on a Saturday, so I think it was like a Tuesday or Wednesday after that, and saying that one of the employees, team members who was in the exam tested positive for COVID-19. And I was like, gosh darn it, I'm like, crap, but that's bad. So of course I went and got tested, and I still self-quarantined. At that time it was 14 days was what the guidelines were, but I was asymptomatic. I didn't have any conditions going on. But then, I've been negative on COVID-19 since, and I still get tested every 2 weeks for COVID-19, being in the healthcare profession. But that was the only time that I've had experience being exposed to it. But when I go to the other, and I just go to the FEMA testing, so they don't submit claims to insurance. But per the guidelines as of today, then they would still put the Z20.828 code if I go to my doctor's office and have it done there. So just remembering that if the patient has signs or symptoms, we code the signs and symptoms first. If they have exposure to COVID-19 or suspected exposure, then we tack on the Z20.828 code. And then we have asymptomatic individuals who test positive for COVID-19. And this actually happened to a friend of mine, was actually in the hospital last November for an unrelated condition, and they woke him up, like you said, like around 2, 3 in the morning, and it was just like Secret Service came in and like yanked the president out of, you know, a dangerous situation where he was like, woke up, he was in the bed, and he was like, oh, well, what's going on? And they just wheeled him up to the COVID floor like that. He didn't know he had COVID. He was showing no symptoms. He still has never showed symptoms. So that is possible. You can have a positive COVID-19 test, but be asymptomatic. It could be a false positive, but you could have COVID-19 and just not be showing any symptoms. And as this guideline states, that for asymptomatic individuals who test positive for COVID-19, see the guideline, the first guideline for COVID-19, as in the U07.1. Although the individual is asymptomatic, the individual has tested positive and is considered to have a COVID-19 infection. So earlier in this chapter 1 part of the guidelines, we saw how we have a symptomatic B20 code for HIV, which also covers AIDS and ARC. But then we have Z21 for asymptomatic HIV. How we have the symptomatic and asymptomatic, 2 different codes for HIV. COVID-19, we don't have that. We just have one code for COVID-19 positive test result, the U07.1. Doesn't matter if the patient's symptomatic or asymptomatic. 2 more parts in COVID-19, then we're done with this section. And then that's it. So personal history of COVID-19. For patients with a history of COVID-19, assign code Z86.19, personal history of other infectious and parasitic diseases. So again, like here, there's no separate code for personal history of COVID-19. They just group it together with the personal history of other infectious and parasitic diseases and the Z86.19 code. And then we have the follow-up visits after COVID-19 infection has been resolved per the guidelines. For individuals who have previously had COVID-19 and are being seen for follow-up evaluation and COVID-19 test results are negative, assign code Z09 and counter for follow-up examination after completed treatment for conditions other than malignant neoplasm, and Z86.19 personal history of other infectious and parasitic diseases. And so here again too, we already looked at the Z86.19 code, but we talked about that like, a minute and 17 seconds ago. But the new code though here discussing it, Z09, encounter for follow-up examination after completed treatment for conditions other than malignant neoplasm, how that is just generic. It's anything but malignant neoplasms, so there's not a separate code for it, classifying the follow-up examination after completed treatment for COVID-19. It's just grouped together with other conditions other than malignant neoplasm. And the last part here now for COVID-19, encounter for antibody testing. For an encounter for antibody testing that is not being performed to confirm a current COVID-19 infection, nor is a follow-up test after resolution of COVID-19, assign Z01.84, encounter for antibody response examination. Follow the applicable guidelines if the individual is being tested to confirm a current COVID-19 infection. So translation, that if patients have an antibody testing that is not being, if the reason for it is not due to COVID-19, then we would just use the Z01.84 code, encounter for antibody response examination. And that wraps up this education on our 3rd installment of the ICD-10-CM Guidelines. And today, again, we cover Chapter 1 in the Guidelines. So it's Section 1C1, covering Chapter 1 in the ICD-10-CM book, certain infectious and parasitic diseases, giving us in the code ranges A00 through B99, and also including the new U07.1 code for COVID-19. So next episode, we'll be continuing on with the ICD-10-CM Guidelines. We're discussing the guidelines for Chapter 2 in the diagnosis book, ICD-10-CM. And from all of us, the cast and crew here of the Paul Chandler Show, we do thank you for watching. Live long, do good, and prosper.